hello, everyone. Hello. We are live with our weekly What's Up Doc. And this week we have Dr. Fadi Saab with Dearborn Cardiology and in Dearborn, Michigan. It was at the request of actually more than a dozen patients in our network that he be a guest on our program. And he has thankfully agreed to be here to answer questions every week. We have our What's Up Doc series where patients have the opportunity to ask questions of a doctor and also share their stories. And so thank you so much, Dr. Saab, for being here. Not only do we appreciate you just tangibly as a limb saver, but also as an amazing advocate. Always, always, always at the forefront of social media or at conferences, really advocating for our patients and making sure that other doctors are educated in the most advanced tools and techniques for limb salvage. So we appreciate you and all you do, and especially for being here today. We have 1 hour to spend with you, and we're really excited to hear your insights.
Thank you for having me. It's always a treat. It's always a pleasure, and at this point, I see a lot of friends. That's how I would call it. So I'm happy to be here. I think everybody in this group has been just as passionate, if not even more, about the cause and spreading awareness. And we need more of you, and we need more CLI fighters. CLI fighters are not only the doctors that are doing the procedures. It's you guys who are advocating for family members and for yourself. So thank you.
And we are going to jump right in because we already have a question that is coming in right now from a patient who is located in Detroit. She had a FemTib bypass, ephemeral tibial bypass, and from above the knee to the calf. And she only had some of her symptoms actually be relieved by this bypass. She went back to the doctor the day, and the doctor said, well, the reason is because you only have one vessel runoff from the calf into the foot, just below where the graft is attaching into the calf. And if we do anything else, it'll just damage the vessels. There's nothing more we can do. Hopefully, after a year following this bypass, you'll start to feel better. But she is concerned that if that bypass graft gets blocked and nothing is done to open the two other arteries, or at least one other artery down in her calf, that the next step, when that becomes blocked, that graft becomes blocked, that amputation is going to be definite. So what would be your best advice for her?
One of the growing areas of interest, and I know a lot of you advocate for that, is having a second opinion, right? So, and a lot of the times, obviously, you don't know the nuances of each case, but a lot of the times, so I'm going to talk in general terms, but one important aspect is if you're not convinced by advice that's being provided by your physician, and most physicians, I'm sure the physician is a great doctor, it doesn't hurt to seek another opinion. That's number one. Number two, I think one of the important questions that patient need to ask is, what are your thoughts about endovascular therapy, and vice versa, right? So if a patient is being treated via endovascular therapy and they're not improving, the patient should ask, well, what about surgery, right? So they need to kind of ask their physician, is that an option? Is that something that can be done? The challenge with what we do right now with critical limb ischemia is there is no way for our patients to know who are the physicians that are able to perform these advanced techniques in terms of revascularization, even surgical advanced techniques, right? I don't think all surgeons are created equal. I don't think all endovascular specialists are created equal. So it is a challenge. That's why it's such a relevant group, what you're doing, Kim, with the support group that you have, because really knowledge is lacking out there. So to bring it back to the individual that's asking the question, I would strongly advise her of seeking another opinion, not because of the doctor is giving her wrong advice. It's just simply to get another opinion. And number two, I would encourage her to ask him about other options. Is there any other surgical options? Are there any other endovascular options that he should think about or entertain? And if he, it's usually hard to tell the physician, well, if you're not able to do it, I think that's usually might be an uncomfortable scenario, right? But she might gently ask him, like, would you consider discussing this with some of your colleagues about any other endovascular options or surgical options? So that's what I would advise the person. I would definitely argue, like, I would not say just take it for what it is and stay put.
We at the Global PAD Association always advise and agree with you to get that second opinion. Um, we're very concerned that there are a lot of doctors out there that will go ahead and fix the faucet. They turn on the faucet, they turn on that blood flow, above, but then they don't check the plumbing below and to make sure that that plumbing below can actually support the extra blood flow that's coming in from the top. There's still so many doctors that don't believe in treating anything below the knee. And I understand you don't want to treat the vessels below the knee too soon. Walking's the best medicine. Any sort of conservative therapy, especially medicines, whether it's blood thinners, making sure you're on the right statins, making sure that you also are on potentially a drug called cilostazol. That's a vasodilator that can help some patients actually walk further and maximize, the bandwidth that they do have in their vessels as they walk. And it could delay any sort of procedures. But the fact of the matter is, you don't want to wait until a patient is a toe stub away from amputation before you actually address the plumbing below, those smaller vessels below the knee. And so many new technologies and techniques are just coming into the pipeline every single day. And I'm curious if you can educate our patients on some of those new technologies and techniques that you're seeing being discussed at some of the conferences in 2024 that are providing definitely a light at the end of the tunnel for many of these patients who didn't have options before.
Right. Yeah. I mean, that's a great point, Kim. Talking about what is currently available, and I'll tell you one of the things that when I meet a patient for the first time, they have critical ischemia, albeit if they have a wound or they have um, breast pain or discomfort that when they're doing nothing. And generally speaking, those patients unfortunately have other medical problems. Could be diabetes, could be renal failure. The conversation is that at least for me personally, when I have a conversation with them, I would emphasize the fact that, look, at this stage, within the last 10 years, we've improved significantly in our ability to tackle blocked vessel that 15 years ago, it's almost impossible to treat or open. What I think the technology is lacking or is starting to catch up is how long we can keep these small vessels below the knee open. Our objective is not to keep the artery open. Our objective is to improve the symptoms and heal the wounds. Both of those objectives will ultimately save the limb, maintain the independence of the patient. And the technology is really accelerating in that space. So there's a lot of new technologies that's being studied or introduced into the field that I think we will see over the next 5 to 10 years, right? So let me give you an example. There are new types of medicated balloons that are being introduced to the North American patient population. It's currently being used in Europe with variable degree of success, but it's also going to hopefully be introduced to the United States within the next 1 to 2 years. There are devices that are being also introduced in the United States, currently undergoing trials. Just to give you an example, a device that I think is very unique. It's what we call a temporary stent or the spur system. It's a device that it's an actual stent that you place in the artery below the knee and you leave it there for 4 or 5 minutes, basically trying to break some of the hardened calcium within the vessel. and then you can pull it back and remove it. And that concept is very attractive to a lot of physicians like myself, because these very tiny vessels or small vessels, especially below the knee, they don't respond well to placements of stents or metal scaffold. It's different than larger vessels above the knee or bigger vessels above the knee. We use those stents sometimes, but they don't tend to perform as good as those other segments in the larger vessels above the knee. There are newer devices or plaque modification or arterectomy devices that are being introduced also to the field that I think will have positive impact on the field. So one of the latest and exciting technologies is the introduction of what we call bioabsorbable stents. So these are stents that you place, and it can dilate the vessel. And over time, a period of 1 to 2 years, the body absorbs these stents, and they're no longer there, right? So all of those technologies are exciting. They're new. They're helpful. They don't provide a perfect answer, but it's definitely a step forward than what we had before. And remember, a lot of these good doctors, they practice in late 90s, early 2000s. If they're not keeping up with these new technologies, they're not going to be aware of it, or in some extreme cases, they might tell you we don't believe in it, like Kim said. So ask and verify all the time. Ask and verify, and ask for another opinion.
Or there are studies that are out there with antiquated data or very biased data. And one thing that has really struck me when I'm looking at the names on certain studies, and I know from either being in the cath lab, or I know from looking at, talking to patients, getting the real patient outcomes, or looking at Medicare data, that these particular doctors may not have the advanced skill set. And so when you see some of these studies out there that are arguing for the limitations of some of the doctors, you have to take them with a grain of salt, and you have to understand that skill set is not taken into consideration. I mean, you can have someone that graduates from medical school at the bottom of the class and the top of the class, and they still have a job and they're still treating patients. And so I know that you can't necessarily comment on that, Dr. Saab, but it is something from my experience, and it's something that's a point of contention for me, that I do think that their skill set, there has to be a way that we can actually be able to look at someone's skill set and be able to determine if they're the right person to be saying, hey, this particular device does or doesn't work. Not every device is going to be the greatest in everyone's hands. Everyone uses a wire, but not everyone knows how to get around the horn in an efficient, effective manner. So meaning, going from one leg to another, in case some of the patients aren't familiar with that terminology. But
Well, if I may comment, Kim, I think you raise a very good point, and believe it or not, I think this is something that a lot of physicians that treat CLI patients are talking about currently. Let me give you an example. In the universe of cardiologists, you're supposed to have a certain number of procedures be performed yearly basis to be considered competent. So for example, you're supposed to perform a certain number of procedures to do stents in the heart. You're supposed to do a certain number of procedures to place stents in the brain, for example, just to give you an idea. Unfortunately, with CLI or critical limb ischemia, we don't have those numbers. And I think, Kim, to your point, um, a lot of physicians that might make an opinion or comment on the success or the failure of a certain technology, or comment on certain approaches. Number one, they're not performing these procedures. They're not experienced to it. I personally believe in the 10,000 hours rule, right? No matter what you do in life, if you do it on a regular basis, continuously, you become good at it. And I agree with you. I struggle quite a bit with um, physicians, and they might be, I believe they're well intending, but I struggle quite a bit with physicians who negate the value of some of these technologies when in reality they're not performing these procedures on a regular basis. That's a challenge. For example, if you ask Dr. Saab, what's your opinion of performing this surgery or that surgery? Well, Dr. Saab does not do surgeries. Dr. Saab does endovascular therapy. I can talk to you until tomorrow about endovascular therapy, but I can refer you to a vascular surgeon that I believe will do an excellent job doing a particular level or particular surgery, right? And I think that's very reasonable. Even in the heart, some of these occlusions in the arteries of the heart, I don't perform these procedures, but there are very skilled physicians that spend hours and hours learning how to do them. And as a cardiologist, I would send the patient to them because I believe they'll do a better job than me performing these procedures.
I think that these are really important points because so many of our patients come to us and I'll say, oh, here's a really great doctor that you could potentially get a second opinion from. And they say, oh, well, they're not, the head of the facility, or they're not at a large university, or something like that. Or they might be the new, the doctor that they have might be on the Newsweek's new list of the top vascular surgeons. And they're like, so I know I have the best. And they can't believe that anyone else who might, let's say, be in an office-based lab or a smaller facility would be as good as these other doctors. And I think this is really important for patients to understand, and that they need to ask questions about the specific skill set. And if a doctor is not willing to entertain your questions where you're asking them, hey, do you treat those small vessels into the calf and into the foot, and what is your success rate? Do you perform not only an antegrade approach, meaning coming down from the groin where you poke into the artery up towards the groin and then come down and tackle the blockage from above, but do you also come up from below and do what's called a retrograde approach? Do you know how to do this if medically appropriate? In my situation, how many times have you done that? What is your success rate? I mean, these are really important questions. And then my favorite one is, do you use, especially here in the United States, I know it's not as prevalent in some of the other countries, to be using intravascular ultrasound. It's like that extra set of eyes that I consider, it's like dotting your I's, crossing your T's when you're performing a procedure. The doctors can actually get a better idea on sizing of balloons and stents. And that can lead to greater durability. If a doctor in America is not using it, I question that. And even for my own dad, we went through 7 doctors until I found that doctor that I believe dotted their I's, crossing their T's. It's not easy to choose a doctor, but your life and your leg are on the line. So you definitely need to put in the time, because not all doctors are created equal. I want to get to our next question. Donna, she wants to know if there are any new breakthroughs with popliteal blockages. She has a 100% blockage in the popliteal artery. She was told that nothing is durable there, so they won't treat it. So is there anything new that could be durable for behind the knee?
So if I understand the question correctly, the person is asking that the artery behind the knee is completely blocked and there is nothing that can be successful in unblocking it or maintaining the vessel open there, if I understand correctly.
Right. She said that was that's what they told her. So she's been walking. She's done a great job building collateral vessels, but now suddenly a year later, she's starting to have a problem with her toe. And she's concerned because the doctor had told her way back when that there was nothing that they could do that would be durable to treat that 100% blockage. So her only option was to walk. And now she fears, if that toe gets worse and it starts progressing up the leg, is amputation going to be her only option?
Yeah. So when you think about peripheral arterial disease, it's a spectrum, right? So the first portion of a disease, which is claudication, fancy word for saying I walk, I get discomfort, I get pain, I get uncomfortable symptoms. So notice I'm not even saying pain. In those patients, depending on the complexity of the disease and where it is and how significant it is, I think a lot of the times it's appropriate to say what Kim said, hey, let's try to control the medical issues. Let's try to encourage you to walk. And the patient will do due diligence and they'll do what they can. Now, if they cross into the area or the category of peripheral limb ischemia, and it sounds like this person is starting to develop ischemic changes, suddenly the threshold to treat is much lower. And I don't believe it is acceptable. Again, I'm talking in general, but I don't believe there is such a thing as we cannot open a blockage behind the knee because there is nothing durable. I think there are surgical options that are viable. I think there's endovascular options that are viable. It depends on the center. That center could be in a large institution, that could be in a small institution, could be an outpatient facility, and it depends on the physician's skill set. So I don't think in this day and age it's acceptable to say that there's nothing that can be done for a blockage behind the knee, or we treat those blockages all the time. So for that person that's asking, seek another opinion.
Fantastic. Thank you, Dr. Saab. Alan, go ahead and unmute. Alan has a question for you, Dr. Saab.
Hey, Dr. Saab, how are you?
Great to hear you from you, Alan.
You treated me about 2 years ago, and we were successful in reopening my femoral artery. I had a thumb pop, and it was synthetic. And I was wondering if there's any new advances out there that have come up or techniques for opening synthetic bypasses.
So the question is there any advances in opening synthetic bypass grafts? Usually, Alan, when these bypass grafts occlude, the classical teaching appropriately would avoid going after them and opening them again if they've been blocked for a while. But I will tell you that in my practice, and I think that's something that you're going to notice more and more around the country, about 15 to 20% of our patients are what we call post-surgical revascularization, meaning these are patients that had surgery, good surgeries, femoral, fem pop, or from above the knee to below the knee, good surgeries, adequate, they served their purpose, they worked for 1, 2, 3 years, whatever it is, or less or more. But they stopped working, and now the patient has symptoms. In the past, and when I say the past, 15, 20 years ago, the surgeons would say, well, there's not much you can do with this surgery, and I don't think we can do it again. Now we can open the native vessels in an endovascular fashion. So that's an option. It's an available option. It's a reasonable option, and quite frankly, even with surgeons who are well versed in limb salvage, they can do another surgery in some of these instances. But to answer your question, if these bypass grafts have been completely blocked for a while, I would say more than 6 months, generally speaking, you want to avoid opening them again.
Okay. Yeah. I just wanted to also say thank you for helping me save my legs, Doc. I really do appreciate it.
Thank you for allowing me to, the privilege of working with you and being a part of your family. I'm just ecstatic that we were successful. So
thank you.
Thank you for participating, Alan. We do have a question coming in on our YouTube channel from Debbie. Thank you, Josh, for bringing it to our attention. She says, I have really bad insurance and have not been diagnosed, but her back has actually been ruled out. And the doctor told her it must be her veins. But a lot of times when doctors say it must be your veins, it might be the arteries as well. She does not have a primary care doctor. Where should she start in the process?
That's a good question. So depending on which area she lives in, if she lives in a large metropolitan area, or if she lives in, depending on the location, I would strongly encourage her. And Kim, you do a beautiful job with that. There's a lot of free screening events. Maybe free is not the right word, but there are a lot of screening events. Hospitals might sponsor sometimes, or certain centers might sponsor them sometimes, and they will do simple non-invasive tests, at least to identify if there's an issue or not. These simple tests are not always bulletproof, they're not always correct, but at least it's a starting point for you to do that. So I would, depending on where you live, I would encourage you to look at if there's any screening events within your community to do something like this. And I think, Kim, you're a great source for that. So
we do, and we actually have a relationship with Lifeline, and we're able to help patients who can't afford Lifeline to have a Lifeline screening, which includes everything from the neck clear through the toes. So they can go ahead and go to padhelp.org or call our LegSaver hotline at 415-320-7138 if they need some help getting screened.
Yeah, here you go. You got your answer.
And they can also, we just had a relationship with, developed with Biomedics, and on our website now, there is the ability on our testing page on our website, patients can go and actually search for a primary care doctor or a podiatrist in their area that offer the Biomedics screening tool. And these doctors can actually perform a PAD test inside their clinic that day. You don't have to schedule on another day. It's right then and there. You can find out whether or not you have PAD. So that's really exciting. Okay, we have another question coming in online from Jody. Jody says she has an occluded femoral artery in her left leg. It looks like she might have had a bypass. She said it failed 5 years ago after being in for 10 days. Is her only option a bypass? She has many blockages in her left leg as well as her right. Her right femoral artery is 65% blocked, and she only has 2 runoff arteries in the lower leg. She has had no interventions in her right leg so far. She has only had bilateral iliac stents, actually, so I guess she has had her other leg treated. So both her iliacs are stented. Seems like she's had a bypass. Is bypass her only option at this point? And I know it's tough, it's very vague, but can you offer her some advice on some critical questions, possibly to ask her doctor to determine what the next step is for her?
Yeah, so I would say right off the bat, when a physician says your only option is this, or the only correct thing to do is this, especially in the field of PAD or critical limb ischemia, respectfully, I have to disagree. So, again, like you pointed out, Kim, very nicely, there's always nuances with these situations. And as I mentioned earlier, about almost 15 to 20% of patients we're treating right now already had bypass surgery, already, had sometimes 2 surgeries, and we will perform endovascular therapy to treat them. And that's something that's not only specific to me, that's something that's gonna grow throughout the United States, that's already growing in Europe, because the technology is improving. The safety profile of endovascular therapy is improving, and the skill set of physicians is improving, especially with the newer generation of physician surgeons, cardiologists, radiologists. What we are able to do from an endovascular approach has significantly improved. So whoever is posing the question, I would encourage you to seek another opinion. Saying that that's the only option, I confidently would tell you that that is not correct. I think seeking another opinion, and you might see another surgeon that will say, no, we can do another surgery, or you might see someone else and say, you know what, we might consider an endovascular approach. So to write this off is I can't think of a reason that it's not allowed or feasible.
And we have a question coming in from Lita. She is asking, she says she had an angioplasty recently in her right leg, and she wants to know if it's safe to take vitamin D2. I hear this all the time from patients because they're concerned about taking D vitamins and calcium, that it's actually going to lead to more buildup in their arteries. What is your take on that?
I am not aware of any trials that prohibits patients from taking vitamins, water-soluble vitamins, or any type of vitamin as it relates to PAD or critical limb ischemia. You hear a lot of hearsay information. I'm sure if you go on the internet, you're gonna find one thing or the other about it. But as far as I know, there's no clear contraindication to being on vitamin therapy for PAD patients. In fact, we encourage it because a lot of PAD patients, believe it or not, are malnourished for a variety of reasons.
Yeah. And we have a question coming in from Janie. She wants to know if you have any experience with patients who have been diagnosed with calciphylaxis with PAD as well as end-stage renal failure.
Yeah, that's a great question. So, um, calcification or hardening of the artery because of calcium buildup within the walls of the artery is quite essential, unfortunately, in the PAD and critical limb ischemia patient population. And the way this happens, it happens over a long period of time. It happens because there's inflammation, meaning there's injury. The body, for a variety of reasons, if you're a dialysis patient or if you have diabetes, the body will manifest um, these changes within itself by calcium deposits within these vessels. So to answer your question, it is something that we expect, we battle, and we are always constantly coming up with new ways to tackle. So the plaque modification or the use of atherectomy device was originally created to tackle these calcification per se, especially in patients that have advanced form of PAD or critical limb ischemia. It's expected to have the calcinosis in those patients. If you're diabetic, if you have renal failure, or if you're on dialysis, I would say 80 to 90% of the patients will have some degree of calcium deposits or calcium buildup within those vessels. So it's anything that we do within endovascular therapy revolves around disrupting that hardening of these arteries. That's why I personally am a big advocate of plaque modification, changing the compliance of the vessel, not just simply pushing the plaque out of the way, because you're really not doing anything to change the mechanics of the vessel. I'm not saying it's a bad thing. I'm just saying, was a very old way of treating the vessels. Now with the new devices, like the temporary stent that I was describing earlier, it's one of the exciting things about it is it actually can disrupt that calcium hardening around the vessel. So if you can imagine, you have a band of calcium around the pipe, and the only way, no matter how much you try to stretch that pipe, there's that band that's prohibiting you from doing that. So if you have a device or any sort of equipment that can disrupt that band, so suddenly that pipe is going to be wider, allowing to deliver more blood. That's where we are right now in terms of new advancement with the treatment. So to answer the person that's asking the question, the field is completely focused on that. That's one of the biggest challenges in the field of CLI, is addressing the calcium buildup within these vessels.
There's a lot of hype right now around IVL, intravascular lithotripsy, and even an article just out, I think it was even just today in the USA Today. It was a contributor, Ethan Stone, that had interviewed Dr. Lee and a Dr. Kaki about this technology. Why are people so excited about this technology, and why are companies, trying to find new ways to create this type of technology? I mean, you have the general one from a company called Shockwave that was recently purchased by Johnson & Johnson, and then you have laser technologies that are coming out. I mean, there's a lot of attention and a lot of excitement around it. I'm curious, just your perspective, some of the benefits and limitations of this technology.
Yeah, so the idea is to create devices that can disrupt and interrupt that constraining calcium or calcinosis structure around the pipes. The pipes in our situation is the arteries that delivering blood to the lower extremities. So the shock wave is basically using ultrasound vibrations, kind of futuristic concept, and sending these ultrasound vibrations to the wall of the arteries from the inside to the outside, in the hopes of disrupting that hardening of the arteries. So it's a great technology. It's being tested. One of the exciting things that I can share with you, that is the use of laser technology. So there's a new trial that's going to be launched soon that we're lucky to participate in. I'm going to lead that trial where we're going to examine the effects of laser beams on sending shock waves to disrupt that calcium buildup. So it's a rapidly evolving field. We're starting to understand why are we failing? Why are these arteries blocking back up again? Remember, we can never make these arteries normal, but if we can do something to slow down the re-occlusion of these vessels until the patient's symptoms are better, until the wounds heal, then everybody wins. And we don't have to do these procedures over and over again. You know, one of the things, Kim, that I always ask my patient, do you rather lose the limb, or would you want us to try to maintain opening these vessels until these wounds heal? And the answer 99.9% out of the time is, of course, I want to preserve my limb. And I think that's the missing piece that unfortunately a lot of the payers don't understand. A lot of maybe older thinking physicians don't understand. And we know now that, losing a limb is not a benign process. It's not like, you remove the leg and you place a prosthesis in it and you just can't stand up and walk. We know it's not a benign process anymore. And that's why I'm hoping this documentary is going to help shed some light, because I don't think the voice of the patients is coming through to the payers, to the insurance companies, to CMS, to even the older mentality of thinking that, look, it's not as easy as you think. It's not a benign process. I need to be able, I want you to do everything you can to salvage my leg.
Actually, it's a good question to pose to the patients. We have quite a few on here. I'm just curious if we open it up for just a minute or two and find out. I'm curious from your perspective, PAD warriors out there. Would you rather have regular maintenance, little roto-rooting, and interventional procedure a couple times a year, or would you rather have an amputation? Even if you know you're simply delaying the inevitable. I'm curious, just go ahead and unmute and we'll just take it as they come. Go ahead and
Definitely
answer.
maintenance.
Definitely maintenance.
1,000,000%.
And why is that? Why is it so? Why are you okay with
Men-
going? It's a lot to
I've
go through these
talked with
procedures.
you and I've talked with Alan. I think I actually talked with Fadi about it before, that mentally, I honest to God do not think I would still be here if I had an amputation. I don't think mentally I could deal with it.
And Alan, what about you?
Well, I can take that from both sides. I enjoyed having my legs an extra year. I mean, I lost the left leg. Unfortunately, it was just a medical snafu, but I'm walking. I'm living. I'm exercising. I'm doing they tell me is incredible things. So there is life after amputation. You can fight and fight and fight, which I'm still fighting with the right, which we pretty stable now. But with a great medical team with Fadi and Jay and Kumar, we're maintaining. And it had to start with that fight 2 years ago. And before then, I was ready for amputation of both legs. But today I can sit here and say I'm living. I've fought through it. And anyone here can do it, including you, Marie. I don't like it when you say that. And fight as long as you can. Preserve the limb, but know that you can get through an amputation. Go ahead.
If you were to go back, would you have had the amputation sooner, or were you thankful to at least, get a good fight in and have your leg for another year?
I'm glad for the extra year we got. We all fought really hard.
Alan, all of us say, sometimes it's inevitable, right? Sometimes,
sure,
despite our best efforts, it's necessary to protect the person, right?
Exactly.
I think what we all talk about here, and unfortunately that's still happening in the United States. We know that 50% of people lose their legs
lose their
without even having an angiogram before. This is what we're talking about. This is in the United States,
Right.
21st century. This is still happening. This is not this group of, I mean, all of you guys are well informed, well educated. I might venture to say that you are a lot more educated than, unfortunately, some of the physicians out there that don't necessarily know as much about this illness and this disease. But we still have people like I still see patients with one limb loss. I'm like, why did the amputation happen? Like, the doctor told me there's nothing that can be done. And now they develop a wound on the contralateral limb, and you question, why did this happen? So hopefully, God's willing, that this type of scenario becomes less and less common with the grassroots movement that all of us are trying to do here by increasing awareness and among among our peers.
And Carol, did you want to chime in? Go ahead and unmute.
If I had to have a procedure every month to save my legs, I would do it. Dr. Saab and ACV, they pulled me through many, many harsh times. And then Dr. Saab ran a test, and my body wasn't metabolizing Plavix. That was a big thing. That's why I was clotting all the time.
Yeah, so you'd rather have regular maintenance than an amputation.
Absolutely.
Fantastic. Anyone else want to chime in on that, or should we get to our next question? Douglas?
Yes, I definitely. Now I'm gonna go against a little bit of the grain here. I'm gonna just be real. There are times that I'm dealing with my axial bifemoral bypass. I wish they would have done something else. And I know it sounds crazy, but sometimes I wish he would have just taken my leg and not put that in there, because I think that has caused more problems with me than dealing with what I listen to Alan. So I'm sorry to go against the grain there, but there are times that I think about it that way.
Mm-hmm. No,
but Doug, you need to cut yourself some slack, because I think what you're saying is, look, it's a difficult disease to live with, no matter what. All of everybody here, even the people that maintain their limb or they're fighting for their limb, we don't. I mean, none of us is simplifying what you have to go through on daily basis to maintain the limb. I mean, just think of even the mental stress a lot of you go through on daily basis, in terms of, okay, well, I'm okay now, what's going to happen tomorrow, what's going to happen in 6 months. So you win a battle, but not necessarily the war. It's a constant state of war against this deadly illness. And if anybody personifies it as much as you, Doug, because God bless you, if I'm feeling down, I read your post. It makes me feel better. So you're an inspiration to a lot of people.
And I think that, he really is an inspiration, and where he's coming from is, this doctor wasn't trained in endovascular, and he only did what was in his armamentarium, which is he didn't understand how to clean out stents. And so when his stents in his legs became blocked, then he went to the aortobifemoral bypass. And then when that became blocked, he went straight to the axillary bifemoral bypass. And meantime, in this whole scenario, not once did he call it PAD. Not once did he tell him to improve his lifestyle modifications. Not once did he give him any sort of medication, such as, blood thinners or statins or anything else, to try and help him along the way. So it kept blocking. And suddenly he ends up with what most doctors I've talked to, even vascular surgeons, would consider palliative care, because the axillary bifemoral bypass, which goes from the shoulder to the groin and splits off to the legs, is literally, it's a Hail Mary. It's a last resort. There's a very high mortality rate with this particular bypass, which is why fewer and fewer are done. And with the increase in new cutting edge tools and techniques for endovascular, meaning minimally invasive with the wires and balloons and catheters and stents, that these particular procedures are becoming fewer and fewer. But for him, unfortunately, his doctor was not keeping up and maintaining continuing medical education with these cutting edge approaches, and went straight for this axillary bypass. And he didn't know to get the second opinion. And because it blocked right away, it's now caused structural damage to his heart. And so it just becomes this cascade, and it's been very frustrating. And plus, not even that to boot, right, Douglas? It was even placed wrong. And now that it's been in there so long, no one can take it out. No one can improve his quality of life with it. And so definitely, Douglas, your point is well taken. And we appreciate you so much, and your strength and your encouragement, your inspiration for so many people. But I do believe, Douglas, you do have a question for Dr. Saab, which is along those lines.
Yeah, and I see it in a lot of groups. Where I talked to a young man today, and he said that's the first thing his doctor said was a bypass, and I think that's very important. Is we all need to understand the importance of getting second opinions.
Yeah, there's still, Dr. Saab, we still have a large contingency of patients who are coming to us with bypass as frontline treatment. No endovascular even considered. And for me, I'm curious from your perspective, but just from my experience and being in, hundreds of cath labs around the world, that there are limitations to that 2D image that you get with a general angiogram. And, it's not until you actually go in and you use a device such as intravascular ultrasound, which is that second set of eyes that I always talk about, that you really understand the morphology of plaque, and you actually take a wire and go in there and you test that plaque to see if it's amenable to that wire traversing it. You just don't know. And we've seen so many cases where someone said bypass, but then we get them a second opinion, they go in endovascular, and they're like, wow, there might have been a tough cap, but once we got through that cap, it was like mush inside, and we got right through. No bypass needed.
I mean, Kim, you know my opinion that the most important rule, I think, and that's what I always lecture to my peers and colleagues, is revascularization, meaning improving blood flow, is always superior than cutting the leg. We know that from studies. This is not just an opinion. I know it's ethically, morally, and mentally better, but we know that medically speaking, improving blood flow is better than just cutting the leg. You might think it's silly that I'm saying that, but we actually had to debate that, and we had to discuss that with some of our colleagues that at some point advocated that, well, you know what, cutting the leg as a first line of therapy is okay. So I think we are bypassing that hurdle. The second step is, okay, well, revascularization is two big categories. It's either surgery or endovascular therapy. Surgery, for the most part, when done appropriately in the right patient with the right type of conduit, meaning the tube to connect the above the area blockage and below the area blockage, does wonders. And there's very talented surgeons. They train for a long time. It's a labor of love for them. And it's definitely appropriate in a lot of cases. But what we're dealing with here is, yes, if you can do surgery, that's good. But what we're dealing with is the lack of knowledge and the lack of awareness in terms of what's available from endovascular therapy. So what we struggle with, a lot of us struggle with, patients, physicians like myself, Kim, you heard it before, is, well, if I can do the type of surgery that really the surgical techniques from the 70s, 60s, late 60s, 70s, 80s have not, I mean, there's some changes, but have not changed significantly, right? But if I can do that, then nothing else works. And that's, I think, where the problem is. And that's what I think is having a second opinion is important. Because remember, endovascular therapy is something that a lot of surgeons can do. So that's something that you have to keep in mind. Even surgeons can do endovascular therapy. And it's very interesting when you talk to surgeons that are trained in both universes, they tend to choose endovascular therapy for patients with advanced form of a disease because they know they'll tolerate it better, right? So again, second opinion, second opinion, second opinion. What you mentioned about asking the physician, it might be uncomfortable, but you have to ask them, hey, how often do you use advanced techniques? How often do you use ultrasound? How often do you use pedal access? And I think, even if you ask it nicely, at least the physician is going to, kind of take a step back and say, okay, this is someone who did their research, and I better, address their concerns and questions. And if that physician gets offended because you're asking those questions, you're not in the right office. You're not talking to the right doctor right then and there.
It's interesting. I've had actual vascular surgeons that have scolded me for teaching patients to ask questions about skill set, tools, and techniques because they don't think it's appropriate for a patient to question a physician about those things because they're the doctor, they're going to them, and they should just trust them blindly. And that is really concerning to me. And I see that a lot. I hear that a lot. I get doc-splained is the way, you hear women say they get mansplained. I get doc-splained.
Well, listen, I mean, it's a unique field because every day there's a new tool, every day there's a new device, every day there's a new technique, right? It's rapidly evolving. This is the AI, artificial intelligence generation, everything at the tip of your fingers, social media, online support groups. This is not, takes 2 years for a piece of information to reach from the academic center to the rural areas. This is, those days are done, right? So, Kim, and actually I say that to the group. I personally had in my capacity as a physician, had so many patients that referred their friends, family members, someone they know, and we were able to help them and save them just by platforms like yours and what you do. So each and every one of you is an ambassador for, that's what I mean. I honestly believe it. You're an ambassador for the disease. You're helping people left and right.
Yeah.
Changing their lives.
That's very true. We have Darlene. Darlene, go ahead and unmute and ask your question of Dr. Saab.
Hi, doctor. I have a question about blockages that return after 3 months after a balloon angioplasty. What causes that? Is it scar tissue or inflammation, or is it new plaque? It happened to me, and I'm not a smoker. I don't have the typical risk factors. So I'm just curious, like, why, when I had a successful procedure on both legs, my thighs blocked up again so soon?
Yeah, so Darlene, that's a great question. It really always boils down to I'm gonna get a little bit technical. So while the ladies are the better half between the men and the females, and all the guys on this group will agree, right, gentlemen? Otherwise, we're gonna get all in trouble. But you are at a disadvantage because in the sense that the female vessels tend to be smaller. And when I say smaller, like the actual diameter of the vessel tends to be smaller. And when the vessel is smaller, then even though when you treat it, remember our conversation about the calcium buildup around the vessel, you will stretch it. The damage that happened to these vessels over the years, it happened over a long period of time, to the point where a patient becomes symptomatic. And when you treat it, sometimes you use atherectomy devices, sometimes you use stents, sometimes you use balloons with drugs on it. But at the end of the day, because the vessels are smaller in diameter, no matter what you do, that plaque does not disappear. It just grows back again. There's also inflammation that unfortunately sometimes accelerates the re-narrowing happening. And this is what I meant by my comment earlier when I first started. We're very good at opening these blocked arteries, but we're just starting to get into, well, how can we maintain these arteries open longer, right?
Mm.
And I'm gonna overstep here a little bit, Darlene. You know, I say that to a lot of my patients. Look, we can sit and say, you know what, this really sucks. But I'll tell you what, 20 years ago, 15 years ago, none of these options were available. And someone would have either lost their leg or suffered miserably for years. So you can look at it this way. And my comment is really intended to maybe point out the half full of the glass, not the half empty, not to minimize or dismiss, you know, how frustrating this is. I can only imagine. I mean, it's frustrating for us as physicians when we, like, in 3 months, everything you worked on has blocked again. So I can only imagine how frustrating it is for you as a patient or for your family. So.
Right. Thank you. We have a question coming in from Don. Don, go ahead and unmute. I think your code name there is DeMarco. Go ahead and unmute and ask Dr. Saab your question.
Hello, are you able to hear me?
We are.
Yeah.
Okay, yeah. In September of last year, I had 2 femoral bypasses, and I'm just curious from a maintenance standpoint, how much imaging should I have and in what frequency, like ultrasounds, to make sure those grafts that were put in are clear?
Yeah, that's a great question. So generally speaking, that's a very important aspect of your post-surgical care. And there is no universal protocol, I guess, so to speak, where physicians say, all right, everybody's supposed to do it or monitor these grafts on these intervals. Having said that, you know, each physician does have a protocol. So that might be every 3 months, that might be every 6 months, but it's something that your physician who performed these surgeries need to be very clear and specific with you about it. So I'm sure he told you like what frequency he wants to do them.
No, not really. Actually, my cardiologist, I have a cardiologist who did one when I went in for just a follow-up visit. And then the actual surgeon wants to do it. She ended up doing one. So I've had 2 done in less than a year.
Yeah, so that's a bit unusual. So what I would, and you seem to be on top of your care, so I would certainly ask a pointed question and say, you know, how often would you like to do an ultrasound image or some sort of imaging modality to check on these graphs that we did?
Okay, perfect. Thank you so
Yeah.
much.
And
Yeah, you're
Don, I have a
welcome.
question for you. Have your symptoms improved? Are you walking at 30 to 60 minutes a day or as
I'm
many days as you
walking.
can each
I'm
week?
actually walking, and I actually took a vacation and I went to I don't know if you all know of a water park called Schlitterbahn in New Braunfels, Texas. I
No.
was actually able to walk the
Doug is
park.
excited.
Yeah, Doug knows. Yeah.
He's
I
in
was able
Texas.
to walk
Well,
for
congratulations. That's
hours.
awesome.
Yeah.
That's awesome.
So, and a year ago when I was at the park, I was in a wheelchair.
That's amazing.
Wow.
Yeah.
Congratulations.
Thank
And it
you.
is
Congratulations.
amazing because one of the things we've had several people that have had bypasses or endovascular procedures both go down, and we always say it's not if they're going to fail, it's a matter of when. And the real idea behind these procedures right now is to give you that much more blood flow so that you can get some sort of pain relief, symptom relief, so you can get out there and walk further and walk faster to grow those collateral network of vessels, those little natural bypasses that you have. So the more you're walking, the more you're out there every single day staying active, even if it does, even when potentially it does, if it does go down, you might have enough collateral vessels that you've built along the way because you are a partner in your care that you may never need to get that fixed. So that's really the good news. So keep going, keep walking, tell those kids you're going to take them to the water park again and again and again.
Yep, yep,
And keep
yep.
walking.
Yay.
Thank you so much, Don. We do have a question coming in from YouTube again, this one from KGC. The doctor said that bioabsorbable stents are used in Europe, and they're working on the clearance process, I believe, here. I think that they, I don't know where they're at. I thought that I saw that they were approved. I'm going to leave that
Yeah.
to Dr. Saab to
Yeah,
address.
they are approved in the United States. They're called the Spirit stents, ESPIRIT. I think if I spelled it correctly.
Is that
They're
Abbott?
being it's by Abbott. That's the name of the manufacturer. They're commercially available, and they're being implanted throughout the United States. These are the stents that I said the body reabsorbs. These stents are, extremely a step forward in terms of how we can treat patients. So I'm always, we're always very excited about anything that can help improve blood flow, especially in these very tiny small vessels. So they are available, to answer your question.
And she says that she's seen a study with mixed results, and she's curious, are there any possible negative consequences when they're on the less successful side of the mixed results? Or what are the factors that could lead to lesser results?
So the trial was public. The results were published in a very prestigious medical journal. So when it was in the areas that were that these stents were tested in, so there's a certain anatomical area, segments within these vessels that these devices were tested in, and they did reasonably well. None of these technologies that we're discussing are perfect, simply because we cannot reverse what the damage that happened to the arteries. And I think it's going to be a conversation with your doctor about the pros and cons of what needs to be done. There has been some concerns about the use of these stents in the heart itself. Maybe that's what she's referring to. There was some mixed signals there. But when it comes to using this type of stents below the knee, or the small vessels below the knee, the results were very good.
Yeah, Marcia's wondering if they're as effective as regular stents.
So this is the part where, like, the geek part of me jumps in. So there's a particular way we physicians try to compare different devices based on statistics and measurements. So the purest way of answering that question is, having a group of patients being tested in one device and having the same number of patients being tested in the opposite device. That type of study was not performed, and most likely will never be performed. So it's going to be up to the individual physician to make that determination. I will tell you that the stents that are being used in the heart have been tested independently in the small vessels below the knee in different capacity. And when used in certain conditions that your doctor should be able to determine, they do very well also.
We have an anonymous question coming in. How long should someone keep trying to walk if their legs and feet are burning and they do have rest pain?
Well, to answer the question in the most pure form, if you're having rest pain, then supervised walking program is not appropriate, and you need to seek an opinion regarding improving blood flow. Now, if we're talking about what we call claudication, I don't want to use the term more benign form, because I don't think claudication is benign. But if you have claudication, which is symptoms when you're walking, and then these symptoms dissipate when you stop walking, that's okay. You can usually try to have structured walking program 3 months to 4 months and see if your symptoms improve. If they don't improve, you need to go back to your provider and say, look, I pushed myself, I tried, because not everybody responds. Some people don't. And I need I need you to recommend something different based on my condition. But if you're having rest pain, then a walking program is not an appropriate therapy.
Great. Thank you. Are there any other questions that we have, or else I'm going to open it up because I'm getting word from several people that have joined this discussion just to share their stories with Dr. Saab. So anyone else have any other questions? Go ahead and unmute. Sheila or Diana, anyone have any questions for Dr. Saab before we open it up? Okay, I'm going to go ahead.
I do.
Oh, go ahead, Marcia.
I wanted to ask you, we've talked a lot and probably the whole time, but I've really paid attention to it lately. Kim will say to try to walk for 30 minutes or time yourself and see if, you're improving the amount of time that you can walk at one stretch. And I'm wondering, I'm really conscious of that now, and I walk a lot, but there are times I don't walk for 30, that I stop. And I'm wondering, is that damaging? Or am I getting the full benefit maybe of walking if I'm not, doing a 30-minute stretch at one time every day, even if I get 15, 16,000 steps?
Yeah, I think any type of exercise, especially walking, as much as you can tolerate is good.
Okay.
We doctors or patient advocates like Kim are greedy. We want you to walk as much as you can, but you're not hurting yourself, you're not harming yourself as much as you can do. That's good.
I guess, am I getting the benefit if
I think it's not like something magical happens at 30 minutes and
Okay.
before that it's useless, and after that everything. No, it's the more you walk the better, so you are getting benefit.
Thank you.
Yeah.
We have a question that is coming in. Sorry, just a few more really quick. How do you know when amputation is the only option or when it's not the only option? That's a loaded question.
That's an important question, and believe it or not, we're faced with this question. We sit down and we have a conversation, and it really depends on multiple variables. Variables like could be an emotional factor, could be family factor, could be a medical reason, could be a technical reason. So there's no really hard and fast rule. I mean, I've had patients that say, we have to do this every month or every 2 months, and I'm just sick of it, and I would like, I just want to move on with my life, and I would like to have an amputation. And I counsel them about, what does that mean, and their understanding of it, and we move. That's a rare situation, but it happened. We've had patients that we attempted endovascular therapy, not successful, had surgery, not successful, or vice versa, had surgery and attempted endovascular therapy, not successful. They're constantly in pain, or the wounds are getting worse. So I wish there is like these are the rules. But I think what's important is having this conversation between the physician and the family and the patient. What are your expectations? What can you live with? What can you do? Is what's acceptable to you? What's not acceptable to you?
Right. And that includes, do you mind, getting your arteries cleaned out just as often as you get your teeth cleaned, right? I mean, regular maintenance later, a little bit of teeth cleaning, you get your little bit of plaque cleaned out of your arteries as well. Now, apples and oranges in a sense, definitely the interventions are more risky than having your teeth cleaned. But that being said, that's kind of how the patients have told me they decide whether or not they want to just continue for maintenance, because they're like, well, I get my teeth cleaned, once a year, twice a year. So why not get my arteries cleaned out? And that's actually how so many people think about it. But the other question that I always ask, when patients come to me and our Leg Saver hotline and they say, I'm on deck for amputation. And I always say, well, is your life on the line? Do you have a wound that is totally infected? Do you have a gangrenous foot, are you potentially going septic? Like, these are questions, especially ones that call us from the hospital. Has your doctor told you that you're going septic and it's either your leg or your life at this point? I mean, those are
Right.
critical situations that you just really do not want to wait. You don't have time for a second opinion, because if you have that, it's either your leg or your life. You're going to have to choose your life. Your doctor will make that choice for you too.
No,
Is they
I
want
always make the comment that um, you know, CLI amputation, it's the only disease where getting rid of the organ is an accepted first line of therapy, right?
You're
It's
right.
a loaded it's a
Yeah.
loaded statement, but it's like, you have no, I mean, it's an extreme example, but you have pneumonia. I'm going to take half of your lung that's infected. So it should not be allowed or accepted to be a first line of therapy. But what Kim said is, valid. Like, but there was a proper evaluation. There was a proper discussion.
Right.
Like, maybe it is the proper thing to do an amputation, but at least there was a discussion. We know what we're dealing with. What we struggle with is never having that discussion, never having a proper evaluation, saying just based on the way the patient looks, you know what, the treatment is getting rid of organ. And that should not be the first answer. Never.
No, I mean, when someone has pancreatic cancer, they don't just go ahead and remove the pancreas, right? They do chemo treatments. They know that the disease would inevitably, at least at this point, in most people, would inevitably kill someone, but yet they try to give that patient just one more day, just one more day, just one more day. And yet I feel it's hypocritical. They don't do the same for these patients with CLI. They're like, let's just cut off the leg.
Right.
And so that's very frustrating for me. And I see this all the time. And did you know more than 30% of people that actually have been on deck for amputation have come to our hotline, have never even been diagnosed officially with peripheral artery disease?
Just very frustrating. That's very frustrating. That should not be acceptable to anybody. And my idea has been somewhat extreme that, no hospital should be allowed to schedule a patient for an amputation without a proper evaluation. And, believe it or not, it seems a reasonable suggestion, but there's a lot of resistance toward it. So I feel very strongly against it. Like, again, look, someone can be evaluated and the proper thing would be an amputation, but at least there was a proper process that the patient went through.
Yep.
But if that does not happen, that's the frustrating part.
Fantastic. I think that's a good way to end the Q&A session. But I just want to, before you jump off, I just want to open it up. I know Douglas has a few points from some folks that he wants to share before we end our weekly What's Up Doc series with you. Go ahead, Douglas.
Yeah, Dr. Saab. I talked to a few people today that were not going to be able to be here, and they wanted me to share this with you. On those days that you're tired, that you're frustrated, that you're aggravated, and all the things that you live with being a doctor, there are thousands and thousands of PAD warriors out here that cannot begin to thank you enough for what you do spiritually, physically, and all that you do for us all around. I mean, so those days that you're feeling that thing, just think about this. There are thousands of PAD warriors that are living a life today because of what you do and your passion and your concern and all that you do for us. And we all wanted you to know that.
Thank you.
Marie?
Thank you. Thank you, guys.
Why you wait till I'm crying, Kim?
Okay.
Thank
Alan?
you.
Well, one thing about bypasses is July 1st marks the day I went into the ER at U of M. And I walked out against medical advice because they said there was nothing else that could be done, that they had to amputate my leg. And I said no, and I walked out. And it was like a week later, I found you, Kim. And you were on the phone and had me in Lansing seeing Dr. Saab in less than a week. And I will never, ever forget Dr. Saab's first words when he was examining me. He just shook his head and he looked at me and he goes, "Oh my God, honey, they've just butchered you." And that's until I got to ACV and to Dr. Saab. That's what they always did. Is it was always these big 6 to 12-inch incisions doing bypasses. And here I'm going to let everybody know, here I am. I still fight. I still have issues, but I'm still standing on 2 legs to this day. And it's all thanks to Fadi. There's nothing I could ever do to repay you.
You don't have to thank me, Mary. Thank you for the privilege of being able to take care of you. Thank you. Thank you, guys. This actually means a lot to me. And listen, we're always supposed to be professional, and you just can't be in this line of work without being invested and knowing the patient and knowing the family and being emotional about it. And I'm not gonna lie to you, there are difficult days. There are good days, but there are difficult days, and I'm blessed to be able to do some of the work that we do. And I made a promise to myself and to a lot of people that I'm not gonna stop fighting this illness, and I'm not gonna stop fighting for my patients and for the people that need this. So thank you. Thank you.
Yeah. No, that's amazing.
Thank you.
Sheila or Brenda or Mike, I know you're not on camera here. Did you want to jump in? Okay. Then
Got
we
one, Kim, real quick, is just to say what a humanitarian Dr. Saab is. He is one of the few men that I've met that is in this field, and how they are such a different person than the average doctor. They all have hearts, and they care about their patients so deeply. And thank you again, Doc, for helping me.
Thank you, Alan. Thank
and
you.
Mike.
Okay.
Mike, did you want?
Yeah, I have something to say. Boy, I'm listening to these conversations and I'm getting emotional. But I have more of a technical question. If we get back to the science, if you don't mind.
Of course.
I'm on dual antiplatelet therapy, aspirin and clopidogrel. And I'm wondering, how is the risk benefit? How does that pan out with taking 2 antiplatelet drugs? I'm wondering if I bruise a lot. I got some nasty bruises on my arms. I'm wondering if just one antiplatelet, I don't know what to do. I go to a primary care physician. I live in Mexico. And sure, I can go get a second opinion, but it's easier said than done. So what's your feeling? Do you use dual antiplatelet therapy on people? Or?
So Mike, I'll tell you what I tell a lot of people that, usually the conversation is, "Doc, look at my hands," and there's a lot of bruising on their hands. And I call it the badges of honor. Or in cases where the men are accompanied by their better half, I say, well, I guess we know who's winning in the fights at home. So the answer is, the scientific answer is, there has been a lot of studies regarding what's the proper way of thinning the blood in a lot of patients. But it's also a spectrum. So you have patients that have extreme cases where there's always clotting that happens within the vessels, and you have to put them on 2 or 3 medications in some instances. You have patients that don't respond. But to answer your question, if you have an advanced form of PAD or CLI, sometimes it is appropriate.
I'm asymptomatic.
So we know the most comprehensive evidence behind anticoagulation are two trials. The most recent one of them applies to you. It's called the COMPASS trial. It's an international trial that looked at patients with asymptomatic disease. And in those patients, they benefited from being on aspirin, which is an antiplatelet therapy, and rivaroxaban, which is an anticoagulation therapy, right?
Oh.
So it's not quite what you have. You have aspirin and Plavix. In that trial, it was aspirin and rivaroxaban, 2.5 milligrams BID, and it had really positive results for patients, even with asymptomatic PAD. So the evidence is not as strong for dual antiplatelet therapy, especially in asymptomatic patients.
Well, I don't know if I understood, or I guess I'll stay on both of them. And just would the bruising be less if I was just on one?
You know, I would push my primary physician a little bit and say, hey, can I be on a single agent? Or if you're on a full dose aspirin, maybe decrease it to a baby aspirin, 81 milligrams. Sometimes that's a healthy compromise. So those are the two questions that I would ask.
Yeah, it's 100 milligram tablet of aspirin. That's what they.
Okay. In Mexico, what they have. So I would ask them that, do I really need to be on both of them? That's not unreasonable.
All right.
Because even Bambi is wondering if it, you know, being on so many can actually hurt the kidneys or other organs.
Correct.
Well,
Risks
I don't
and
know.
benefits. Yeah. Thank you so much. Thank you, Mike, for your question and sharing. And Dr. Saab, I know you have to get to another meeting. I appreciate your time and you being here, and thank you for all you do for so many patients, not only in Michigan, but around the world, and being such an inspiration. Thank you.
Thank you. Thank you, everybody. Thank you for your kind words, guys. I love you all. Thank you. God bless you. Have a great evening. Thank you.
And for those of you that are sticking around for a moment, we did have a question come in from Bambi, and I can answer the question with a video from Dr. Anita Duwa. And it's a video on walking and building collaterals. And so we'll have to sit through the commercial just a little bit, and then we'll go ahead and
I tell all of my arthritis patients to make.
Here.
Number one, you have to start drinking more water. You wouldn't believe how dehydrated most people are. Number two, you need to make a
Medical Notepad, brought to you by patient advocacy organizations Take a Stand Against Amputation and The Way to My Heart. Here is Dr. Anahita Duwa, vascular surgeon with Mass General Hospital in Boston, Massachusetts, talking about how to walk effectively to improve blood flow if you have narrowed arteries in the legs, known as peripheral artery disease.
Peripheral artery disease in the intermittent claudication sense, when you have a situation where you do not have wounds and you do not have what's called rest pain, where you're just sitting there in your chair but your leg hurts a lot. So you're not in that category. We're just talking about purely here, it hurts when you walk, whether it's 5 steps or 100 steps, it hurts when you walk. That's the intermittent claudication. That patient can really, really turn their life around by walking. Now, how do you do that? This is how you do it. You wake up in the morning every day. You commit yourself to 30 minutes of continuous walking. But here's the ticket. It cannot be, I go for a walk with my spouse, you know, down a couple city blocks, stopping to pet someone's dog, stopping to check if they're fresh avocados. No. Every time you stop, the clock restarts. So what you would need to be in is either in the mall or on a track where you can continuously walk. Because you need to turn that watch on. So you got your iPhone or whatever you have to time yourself. You turn on the timer and you start walking. And I don't care if you walk 7 steps or you walk 7 miles. You document. I walked this far today in time, right? Before the pain set in. And then you document, I walked this much further with the pain. Because that's what I need to know. I don't care how far you walked. I want to know how far did you walk when it hurt, because that is what's building those blood vessels. You can walk for 7 miles, okay? But on that 7.1 mile, when you start to feel the pain, that's when you need to give yourself another 5 to 10 minutes of walking to the point where you're actually limping, because that's where you're basically, your body is saying, you know, you've got a tribunal basically that sits in your body that has a certain amount of resources. And it has to decide, what am I going to do with these resources? Where am I going to lay down new blood vessels, right? And if you hurt your body essentially by walking, the legs are telling the body, I need you to invest in me and create new blood vessels in me so that I no longer have pain when I walk. It's no different if you were working out in the gym and you're doing a bunch of reps with your biceps and you get that pain in your biceps when you're working out. What do they tell you to do? What does your instructor tell you to do? Oh, give me one more, give me one more. Why? Because it's in those moments when you have that severe pain where you're actually going to be building blood vessels. You can do 100 reps like this, no big deal, but it's that last 2 that build it. Exactly the same physiology in the legs. It's no different than if you live in a city and you have a city council and there's a crappy road outside your house. The person who goes and complains 1,000 times, screaming and yelling and picketing and chaining themselves to the city council is going to get money to get that road built. The person who doesn't is the one who's going to get nothing. And in fact, they might let the road deteriorate more. And that is what happens when you don't walk, when you have intermittent claudication. Most people will stop walking when they're in pain naturally, right? And so, and a lot of doctors will tell you even to do that because they don't know. They don't want you to get injured. Your PCP may not know. If you get one of those little chairs that you can flip out and sit down, that's ideal, because then you don't have to go somewhere to sit down. You sit down, and the minute that you can go again, you go again. And you do that for 30 minutes and you document each time. How far did you walk? How far with pain? How far did you walk? How far? I guarantee you, I will give you this in blood writing, okay? That if you do that in 6 months, you will increase your walking distance and decrease the amount of time that it takes, basically, that you have to sit down, essentially. So you'll be able to walk further with less pain. And that's what this whole creating new blood vessels is, because what's happening? The city council in your body is building that road for you. And you have a little piece of blood vessel down in your ankle, a little piece of blood vessel up top. It makes the connection for you. So it doesn't open up what's already gone. It doesn't do that. But it does create these new connections for you. Are you going to be able to run the Olympics? Unlikely. But are you going to be able to enjoy your lives? Go out to the mall, go to a movie, you know, walk around, do what you want with your grandkids? Yes, you will.
And that was Dr. Oneida Dua with Mass General over in Boston. And I'm hoping that for Bambi, I hope it answered your question, and hopefully everyone got a little extra inspiration. And I can listen to that video over and over again, and it just inspires me more and more every single time to just get out there and walk more and more. But I think that it's the best explanation I've ever heard about not only, you know, the fact that walking does build collaterals, but how to walk effectively to build those collateral vessels. I can't tell you how many people have said to me, well, my doctor said to walk, but I just assumed that when I get pain, I'm supposed to stop, that I'm going to hurt myself. And that's the case when you have an issue with potentially a pulled muscle or something of that sort that's causing the pain. But if you are having a blood vessel issue, the pain is actually good, according to Dr. Oneida Dua. And I want to jump over to Douglas, who's showing us a milestone that he had. He's been really pushing himself. And if you were here in the beginning, when he was talking about how frustrated he is with, you know, multiple bypasses, just leading him to a poor quality of life. And yet he pushes himself every single day, and he is signing up for 5Ks. And Douglas, every single Monday, you're out there, you're now part of a new walking crew. And I think that, how far do you walk every Monday?
It's a 10-week session every Monday night. It's a 5K, which is 3 miles. So one of the people in the running group volunteered to walk with me every Monday night that I join them. So I've been going 3 months. Last night was the 4th Monday, and I started off at an hour and a half, and then I finished the second one, and then I finished the third one, and then last night I walked a 5K in 6 seconds under an hour. Now, that's not to say I didn't stop. I did stop last night, I think 4 times altogether, but I stood there for a minute and then I kept walking, but I was able to make it. So
Good job.
we can do it.
Yes.
Way to go, Doug.
Yep. Nice job. And I think that's a good note to end on. I appreciate everyone being here and for engaging with Dr. Fadi Saab. We're trying to do our What's Up Doc weekly because so many people have questions for doctors that they can't get answered in a timely fashion. But as you know, every time you join in, every time you watch these programs, remember that the advice and views offered are that of the individual physician or of me or of the patient. Make sure that you do not act on any advice or information offered in any of our series, especially the What's Up Doc, without the explicit consent of your own healthcare provider. And if you do have further questions and you need some help, make sure you go to padhelp.org or call our LegSaver hotline at 415-320-7138. We can help provide you with additional comprehensive personalized education, high-touch advocacy, helping you prepare for appointments, showing up to help advocate for you during appointments, and then supporting you afterwards with lifestyle modification. So we are here for you whenever you need us. So never hesitate to reach out. And by the way, don't forget to like our channel, our YouTube channel, and make sure you subscribe, and you will never miss any one of our pieces of programming, because we have a new series that is launching on Wednesday, and it is with a nurse practitioner that is going to be taking more of a functional medicine approach and talking to you about nutrition and supplements. It's something everyone continues to ask about. And so make sure you tune in for our first one, which is on Wednesday. It is at, I think it's 9:30 a.m. Pacific time, 11:30 a.m. Central, 12:30 p.m. Eastern time. And I think that would be 5:30 in London. So hopefully I've been able to help you to figure out your time zone and when to tune in, but it's going to be on the same channel, same YouTube channel. And if you do have our Zoom link and you are here in our studio audience today, you can just use this same link for tomorrow's event as well.